intubation, sedation, respiratory therapist, that's some good, great EMS there. Respiratory therapist at the bedside with a ventilator. Which ventilator setting is most commonly used in ED? It's the only one I do. Yeah, it's just control. So, that's an easy question, right? We would never make it that easy on the test, that's for sure. So yeah, things to remember basic settings. So, respiratory rate, 10 to 12, each 5, 6, 6 mils per kg, usually appropriate, and then titrate that oxygen to, 95% or more. Let's do another one. All right, that starts with a marathon runner, so probably not a cold injury. Marathon runner stops at the medical tent at the halfway mark, complaining of headache, dizziness, and leg cramps. No abnormalities in the neurological exam. Vital signs are blood pressure 110/70, heart rate 115, respiratory 20, temp 101, SpO2 98% room air. What is the appropriate mean treatment? I like what you guys said. Yeah, I was thinking the same thing. Like, let's do D. I was gonna Google it because I've never seen a rectal cold water lodge. I was like, I better not. Better not see what this actually looks like. Yeah, this one's gonna, start oral fluids and electrolyte solution. So this is gonna be like heat stress or, so vitals are stable. Temp's not in that 104 heat stroke range, and the patient's mentated appropriately with a normal neurologic exam. All right, let's do another. 42-year-old male firefighter brought in by EMS after sustaining 30% TBSA, partial thickness burns to his abdomen and bilateral legs. No evidence of trauma. Initial vital signs: blood pressure 102/70, heart rate 124, respiratory 28, SpO2 85%, on 100% oxygen, Vietnam breather. The patient weighs 100 kgs. After securing his airway, placing the patient on the vent, what is the appropriate volume of LR to be administered for burns using the rule of 10? Hopefully y'all don't need a calculator. I say guys about the test, like the only thing we had on there was GCS. It's like GCS of 13, somebody's got a calculator out. I was like, come on. You don't need a calculator. GCS of 13. I guess he didn't want to take his shoes off or something. He's like, oh, man, it's more than 10. Get my calculator out. All right, what do we think? C. Yeah, C, right? So rule of 10, 30 times 10. And then he's, every 10 kgs over 80, we add 100. So 500 milliliters. I guess last one. There's a wonderful textbook. If you ever need a weapon or something, it's pretty big. Did they actually give you guys this textbook, or is it digital? I was going to say, man, because it's big. All right. So we'll talk about the different cold injuries today. And really we separated like non-freezing versus freezing injuries. Talk about hypothermia, frostbite, all the fun stuff that we don't see very often here in Texas or South Texas. But when it does get cold around here, people get crazy, man. Like, if it gets below 60, people have parkas on. I'm sure it froze while y'all were here and you saw it. All right. So, yep, cold injury has been around, obviously, forever. Particularly important during, like, military operations. So, like, I had the unfortunate privilege to be stationed in Drum and in Alaska, Wainwright, so we saw a lot of cold weather injuries. I mean, actually not as many as you'd think, but, every time I went to the field, there's at least a couple frostbites and a hypothermia patient. So it is something to consider. We also, you see it at all kinds of places, but you can see trench foot and immersion foot. But, it's a multifactorial process. So how long were they exposed? What sort of, what were they wearing out there? And then there are some individual factors we'll look at, which is pretty much the same risk factors for just about everything, you know, drugs, alcoholics, homeless people, all that fun stuff. But, you know, the typical, we have freezing versus non-freezing, so like frostbite's your prototypical injury. You know, it has to be below freezing in order to get frostbite, which makes sense, hopefully. But non-freezing conditions, these are usually from wet conditions, so this is where we see this a lot. And, you know, trench foot is going to be probably our most common one, also called immersion foot. We saw a lot of this like at JRTC, depending on, you know, the times of year. People spend all day in swamps or all night in swamps, so you'll get trench foot, and you know it can cause, you know, significant so you know morbidity, especially during your operations, depending on how many people. There was like an entire platoon one time. Was somebody in this class part of that? Yeah, we had like a trench foot mass out there. It really was like 37 people. So, you know, it can affect soldiers. Good news is we don't do a lot for it other than just kind of monitor them. But risk factors, same with everything: homeless, alcoholics, drug abusers, psych disorders. And then the pathophysiology, you know, multifactorial, just pretty much like everything else, right? It's all multifactorial. But you get some sort of soft tissue injuries, it affects peripheral nerves, and, you know, accelerated by those wet conditions. So, you know, a lot of what we do for this is prevention, hopefully, if we can. And that's why we tell people to bring, like, you know, lots of socks, change out your socks, dry boots. A lot of the problems will be, you know, especially like when I was in the light infantry, everybody wants to pack light, so they're like, we can't pack extra boots, and then so they show up with trench foot, and apparently they don't have extra socks either. But early, you get the tingling and numbness, so it looks pale mottled. It'll be, you know, might be erythematous, and then it leads to like pulseless, immobile. Typically, you know, just mainly on the toes and foot. Once they start rewarming, it starts to become really painful. So they get that severe burning sensation. You get edema, blisters, like you see in the picture there. And then they can have like sequela for, you know, sometimes weeks. So a lot of times, like when we would have this, you know, they usually can't go back to the field, and they have to be monitored until they start to improve. But it can lead to permanent disability, which is unfortunate. So that's why we try to treat this and identify as soon as we can. But treatment's supportive. So the main thing, you know, take them out of that environment, get them into some dry, get them into a dry environment. We want to then clean, warm, you know, rewarm them. And then the goal is going to be just keep them warm. After that, you know, what we like to do is prevention. So making sure they have, you know, lots of socks they can change out with if they're wet. Trying not to sleep in wet socks. That's what happened to that platoon. They like slept in a swamp, which is never good. Another rotation I had, it was a hypothermia because they slept in a swamp, and I was like, I don't know, I feel like I guess some soldiers just listen really well and don't complain. I'd have been like, nope, I'm a little cold right now. I'm gonna get out of this swamp. But once the symptoms begin, you know, make sure you warm the feet, dry them, elevate. Most of it's supportive care. There are drugs that we can use for it. I've never used any of the drugs for it, but like Limiprost is one of them that can help increase that blood flow and inhibit splenic aggregation. I'm just wondering if I would doubt we have it at most places actually, but I've never tried to order it, so I don't know. But so that's our non-freezing injuries. Now we're going to the freezing injuries, which is going to be like our prototypical injury, frostbite, and then hypothermia. So, you know, obviously people that are predisposed are going to usually be outdoors, especially, you know, with military activities or operations. I had they wanted to do an operation one time. It was like super cold, freezing, like snowstorm, and they wanted to do like a river crossing and use Zodiacs that all have holes in them, and I was like, this isn't gonna go well, guys. So, like, I don't think we should do it. Luckily, they didn't do it and listen to me for the like only time they ever listened to me. For your medical recommendation over there, so whatever. We'll fix it when it happens. But yeah, wind is going to increase it. Being wet is going to increase that heat loss. And this one you got to have some, it has to be a freezing temperature, so below 0 Celsius or 32. And then it can develop real quick, like in Alaska when I was there, it would get into like -60s. And so you can get contact frostbite. So like even when you're pumping gas, you stick your hand on the little metal handle, you can get contact frostbite like in seconds on there. We still wouldn't wear gloves when we did it, we would just do it real quick and deal with the like pain for a minute. But most commonly, so fingers, toes, nose, ears are gonna be where you commonly see frostbite. And then hopefully it makes sense, you get, whatever that digit is or wherever it's being affected, it's going to cause some sort of freezing, which then leads to tissue injury. Especially once you start rewarming, then is when you see that significant damage. So usually it's during the thawing event, and then the freezing thawing causes all sorts of downstream effects in those digits. So you get thrombosis, it can become ischemic, necrotic, and then lead to gangrene. Unfortunately, as you get further in the like stages of frostbite, you can start losing limbs. And you guys haven't learned burns yet, have you? So we kind of classify burns like this too. So we have different zones and zone of damage that it has. So we can kind of look at like on visual inspection and kind of determine how severe we think it is. So like the most superficial is going to be that zone of hyperemia. So it's going to be like red or erythematous. And these ones, are usually minimal. They can recover relatively well from that. Your most severe is going to be your zone of coagulation. So that's going to be irreversible damage. And we'll show some pictures what it looks like here, but they can look pretty nasty and significant. And then we have our middle ground zone of stasis. So possibly reversible. And we'll look at some pictures of ones, and you can see where the damage was and where it was reversible as we go through some of these pictures here. But our goal is kind of, evaluating kind of stage where we think that, or what zone is being affected and how significant severe it is, and what we're going to do for our treatment. But here's kind of the classification. So first degree is just numbness. You get that central pallor, it becomes erythematous, you get some edema, desquamation. And then second degree, it's similar to kind of like a burn, right? Second degree burn starts to get blisters. So our second degree frostbite, you start to get blistering, the skin, edema, erythema. And then third degree is like tissue loss. So over the entire thickness of the skin, you get those hemorrhagic blisters. And then fourth degree is going to be like down basically to the entire digit, the deep structures, the bone. It's, that nobody's coming back from that, unfortunately. So there's what I talked about already. So partial skin freezing for your first degree. Sometimes they call it frost nip. You can get that desquamation later. It hurts. It's stinging, throbbing. This one has a good prognosis, though, just like first degree burns do. So we kind of classify it in similar fashion. Then our second degree is that full thickness skin freezing. They get the edema, redness, start to get blisters. Then you start to get the desquamation. Patients will complain of aching, throbbing, kind of similar symptoms to first degree. This one still has a good prognosis, and then as we move into the deeper structures, it gets worse. But here's like our second degree, so you can see those blisters, mainly affecting, the distal digits there. And then our third degree is when we get down to that subdermal plexus, so you get the hemorrhagic blisters, necrosis, you get a blue-gray discoloration. Apparently, it feels like a block of wood. This one has a poor prognosis, and let's look at some pictures here. So here's how it looks initially. You get those are more like hemorrhagic blisters on there, and then fourth degree, we get extension into subcutaneous muscle, bone, so basically the entire digit. And then it'll start to form that mummified black eschar. Let's look at some pictures. Ugh, that is just not good, man. Not good. And then here's a great picture of how it looks. And like you can see, it's hard to tell here just because you got the that SCAR now, so I'm trying to identify like the different zones on there. But you can see that like left thumb did recover decently, but everything else, they had to amputate, so it's unfortunate. But let's talk about some management here, diagnosis. So it's clinical diagnosis, based on your exam. Like I said, most common places, nose is very common. Like when I was a private, I was in Alaska and like I had a first sergeant, and he was yelling at us, telling us if we get frostbite, you get Article 15. And the dude had been out hunting during hunting season, and he got frostbite on his nose, and it was like had eschar was black, and I was like, this is interesting. Like, I wonder if he got Article 15. And we were like, okay, whatever. But yeah, it was funny. But typically we just kind of classify it as a superficial versus deep. So we don't have any great lab tests for this. We can do bone scans on it, which can help guide therapy, angiograms as well, so we can look at that like vasculature, and it can have some therapeutic value after we rewarm that patient. All right, so what do we do for frostbite? Well, we want to rewarm them, but the first thing we want to do is obviously get them out of that cold environment. So pre-hospital, we don't want to thaw that just because the risk of freezing and refreezing can cause significantly, more further morbidity in those patients. So initially we need to remove whatever that wet. If they have any wet constrictive clothing, we immobilize, we elevate it, we can get them pain controlled so we can get them from the pre-hospital to the emergency department or wherever we can rapidly rewarm them. So the best treatment is going to be like a circulating water bath, typically, less than 104 degrees, but we prefer like 98 to 102 for these circulating water baths. We don't have anything like that in Texas. I wonder how they monitor that temperature, like in a colder environment. I never worked in the hospital when I was in a colder environment. It was always out in the field or roll one, so I wonder how well they manage that. But other things to consider, that life-saving tetanus. So we want to update their immunization status, which we don't have to worry about it in the military because we make everybody get their immunization, but it is something most people do not get in the civilian world. And then we need to use great pain control, so opioids are probably going to be one of our first lines for frostbite. Then we want to elevate, we don't want them using that extremity while it's healing. And then here's kind of an overview of like our core treatment. So, some sort of immersion with that circulating water bath, help rewarm that extremity. We want to give them some sort of narcotics for this, and then further management, we can use top valve air cream. We don't want to debride anything acutely, and then we just kind of do local care, make sure it doesn't get infected, because we're always worried about secondary infection with anything in the skin. You can also use like anti-inflammatories, things like that will help in these patients. And the big thing, like especially in a more pre-hospital environment, make sure we don't have any refreezing, so don't start your treatment until you get them to a safe environment first. And then depending on how severe, we can look at whether we need to do any imaging on them, like any angiography. And then there are like non-light therapies. So most of those are managed like, frostbite can be managed at like certain burn centers, might management, depending on where you're located at. But we treat them similar to burn patients. What's our disposition? So, if it's just very superficial and we can ensure that they're not going back to a cold environment, then we can look at discharging them, but we have to make sure they have good follow-up so they can see somebody usually the next day. If not, then we need to admit those patients. Anything with a deeper frostbite injury, we're admitting. We want to make sure they have good pain control, anti-inflammatories. Now we want to avoid anything that can cause further vasoconstrictions, like smoking, nicotine can cause it, alcohol. So we want to try to avoid those things if we're going to discharge them. Hypothermia. So now we're still, in our freezing injuries, but any drop below that 95 or 35 Celsius is what we consider hypothermia. And then we classify it like what caused it, basically. Was it primary, they were in some cold environment, or was it secondary due to impaired thermoregulation, which, like our sepsis patients, there could be, there's a, giant list of things. Burns can cause it, birth, anybody that has, really old, really young, malnourished, anybody that has like impaired shivering, we can cause, they're at higher risk for hypothermia. And then certain medications, so like, vasoconstricting medications especially can cause this. Metabolic disorders, sepsis is one we always worry about, and then trauma, that's why we want to make sure we warm our trauma patient to avoid that hypothermia. That's why trauma rooms are like 95 degrees a lot of times. So here's kind of what we talked about yesterday for heat injuries. Here's a great picture of it though, so if we remember like conduction, the different ways we can lose heat. So we have conduction, convection, evaporation, radiation. And our goal is to minimize any sort of heat loss, so we usually want a really warm room. Like I said, trauma rooms are usually extremely hot when you're working in there, so everybody's, and then you gotta put gowns and everything on, and masks, and it just becomes like a big sweat fest. But we wanna dry the patient, provide some sort of insulation like a blanket, protect them from any wind. One of the concerns is going to be like our cardiorespiratory response with hypothermia, so we worry about like dysrhythmias especially, and depending on how cold it gets. So usually anything below 90 or 32 Celsius, that's when we start to worry about some sort of dysrhythmia. And we always want to get an EKG on these patients. And we'll typically see bradycardia, prolonged QR. We may see that Osborne wave, and we'll show a picture of it on here. We may see dysrhythmias like AFib. Or flutter are commonly seen. But the respiratory changes, initially they're tachypnic, trying to stay warm, and then they start to get like decreased minute ventilation, and then eventually lead to respiratory arrest and cardiac arrest. So we always want to make sure we're monitoring their rhythm when we have a hypothermia patient. But here's a great, picture of our Osborne wave or J wave. This one also has AFib with slow ventricular rate, which we normally don't see. Normally a rapid ventricular rate with a lot of the AFib, that's what we get concerned about a lot in the ER. And then our metabolic response. So, you get vasoconstriction, which then leads to, what the kidneys think is a hypervolemia, so you start to pee more, you get cold diuresis. You get rhabdo, like a pseudo-rigor mortis. It can lead to that coagulopathy, which is why we, think about that during our trauma patients as well, because we got that lethal triad. So what are the clinical features? They're cold. So they got a temperature less than 95. Now they may feel cold to the touch. Once you treat lots of patients, you'll start, you'll be able to hopefully feel on an exam like, oh, this patient's hot, they're cold. But they should have some sort of history of cold exposure unless it's secondary cause of hypothermia. So, probably not seeing a lot of hypothermia here in South Texas, but, other places, there's definitely a consideration. Out here, I'm more worried about secondary hypothermia. But depending on what stage it is, you start to see like mental status changes, vital sign changes. Our goal is going to be get a core temperature on them, so we want to make sure we're getting, usually a rectal temperature is going to be our best initial core temperature for these patients. And then, this is pretty small to see on here, but we have different stages of hypothermia, and they, can have different signs and symptoms of physical exam findings. But typically, the mild, anything like below 95 or 35 to 32, so like typically like 95 to 90, they're conscious, shivering. In those patients, we just need to warm them. We'll go into the treatments here on the following slides. When you get stage 2, they might just start getting impaired consciousness, especially as their temperature drops. And then as you progress, stage 3 is going to be unconscious, but they still have vital signs. And then stage 4 is going to be cardiac arrest. So that's, typically it's got to be below like 28 Celsius or 82, which is really low. I've actually never seen a patient that low of temperature. I would be surprised if we got them back, but maybe we can. So here are the different core temperature measurements, and most of these are once we actually have, once we've kind of stabilized them. If they're intubated, you can do esophageal probes. Bladder probes, probably the most common core temperature one I've used. So some of your Foley catheters actually have a built-in temperature probe in them, and then it hooks up to your ProPax and your vital sign machines. So that can give you a decent one. I've never had like a continuous rectal probe or seen one, but they're probably out there. Whenever you do things like that, your nurses get really mad at you. So we usually try to avoid those, but you don't want to use any oral or IR, like the forehead temperature ones. I don't think they use tympanic ones in the hospital very frequently. Maybe pediatrics does, but most places don't. You don't want to use one of those either. So for diagnosing, the big thing, was this a primary or secondary cause? Obviously, like I said, South Texas is probably going to be secondary. Things we want to consider, especially if they're like unconscious, is this some sort of intoxication, toxidrome? Sepsis with hypothermia is never a great sign when you see that. It's usually poor prognosis, and you got to figure out what's going on with them. Sometimes you can see a DKA, pancreatitis, things like that. And then we always say they're not dead until they're warm and dead. So if they were in cardiac arrest and their temperature was hypothermic, we want to warm them up before we declare death on that patient, or we stop that resuscitation. In labs for these patients, we're really looking for any of those like secondary causes with our labs. But we want to make sure we get an EKG on them. May or may not get a chest X-ray. Potassium can be helpful, especially in those cardiac arrest patients. And potassium over 12, not conducive with life. So our treatment is really, a lot of it's just our ACLS type treatment or basic life support treatment for these patients. If they presented hypothermic, we want to start rewarming them and prevent any further heat loss. And then figure out what the cause is. So is this secondary or primary hypothermia? But here's how they present in treatment for the different stages. So mild, they're still conscious, they're shivering, they're mentating appropriately. So these ones we just want to rewarm, take any wet clothing off that they have, place them in dry clothing if we can. And then just give them some sort of warm drinks. We can, have them move around. Anybody, that's a trauma or say other comorbidities, we want to manage them, based on our stage 2 guidelines. And then moderate hypothermia, so stage 2, this is going to be, below 90, but down to 82. And this is when they start to get impaired consciousness. They may or may not still be shivering. And we just want to make sure we're carefully handling those patients because we can cause further dysrhythmias in them. And this is when we start to do our active rewarming in these patients, cardiac monitoring, core temperature. So these ones we'll typically use. Bear huggers are a common one we have in the emergency department. We'll show a picture here. Unfortunately we don't have them in the medical equipment sets for the military, but Roll 2 should have them. My Roll 2 didn't. And we were in Fort Drum, which we probably should have. But we need to use something for rewarming. So warmed IV fluids to prevent any cooling. So if you have a warmer with fluids, that's when we're going to use them appropriately. And then watch for those dysrhythmias. So AFib, flutter. You'll typically have a bradycardia. And we just want to continuously monitor them until, as we rewarm them. But here are some of the different methods we have that we can use. 5 is like that insulating blanket. So that's kind of what it looks like. It looks like one of those those mattresses you float on, and it shoots warm air in them. We usually place that directly on the patient, and place a blanket over top of that, and it rewarms them relatively quickly, and it works well. But we can put, especially like in the field environment or in a Roll 1, we would use sleeping bags a lot of times, space blankets. We have hypothermia prevention management kits work really well. You just got to be careful with those. They get real hot and you can burn the patient if you don't put something in between them. But those are all great treatment options. And then severe hypothermia, so stage 3 is going to be unconscious, but they still have vital signs. So Same treatment as stage 2. We want to rewarm them, monitor their cardiac activity, and then these ones they can get like the ECMO. You guys talk about ECMO? Yeah. So really, it's almost like similar to like a bypass type thing. So you have like venous ECMO versus arterial ECMO, and really you're just taking the blood out, you're oxygenating it, and you can do a lot of different things with it. But you have to go to an ECMO facility for it. I think we have like 2 in San Antonio. BAMC is one of them. So anybody going there will learn what it actually is. Like I only heard about it, like your ACLS and stuff before I did my fellowship. And then we had to do ICU rotations at BAMC, and I was like managing those patients. I was like, oh my God. Yeah, it's impressive. There's all these machines, and like one of the patients, this was during COVID, his lungs were, he basically no longer had lungs, so they had put him on ECMO, so they were actually like bypassing the lungs and oxygenating the blood for him. It was pretty cool. And then stage 4 is going to be our cardiac arrest. So, depending on how hypothermic they are, it can be difficult to feel for a pulse, but they're going to be unconscious, so, we're going to start CPR on them, and then we're going to use our same ACLS protocols for them. So, typically we do, if it's a shockable rhythm, we'll do 3 cycles. We'll usually give epi just like our normal ACLS protocols, and then our goal is rewarming those patients up to 32. Since we can, post-arrest, we can do, we cool them sometimes, so we don't want to bring their temperature back up to normal if it was a hypothermic patient. If we get ROSC. And then what's our disposition? So most of these patients are going to be admitted. If you have, a primary cause, you figured out what the exposure was, you rewarm them, and you can ensure they're not going back to a cold environment and have good follow-up, you may be able to send them home. But most of them, we're going to keep in the hospital for at least at a minimum 24 hours. And anything more severe, the higher stages, we're going to keep them, in the hospital for, quite a bit longer than a 24-hour observation. And then, special consideration. So, children, do we need ECMO for these? What was the cause of it? These are all things we consider. We're definitely not treating any avalanches down here. All right, I know it was fast and it was a lot. What questions y'all got? Let's take a 10-minute break and then we're gonna move into the next lecture. Oh, we're gonna do the abdominal trauma lecture for the next one because it's a little shorter than the other ones are longer. So if y'all haven't downloaded it, please do.
Still getting out of trouble. I mean, this all I'm sure is giving you all the and this is the and this I'm telling you.
I thought that was so funny. You guys
now is the
already started. Already started.
Yeah. Yeah, so yeah. I mean, I know the district coordinator, Wagner, but that's it. I've never Ernie.
Goes to
One of the church, and I was like, I really want to take this book too lightly.
Text me first and say, hey, I don't know anybody important. Alright, let's do this. Shorter, one of the shorter lectures, because surgery will cover it a lot better than we do. For us, we're like abdominal trauma, we need a surgeon. That's how I look at it. Yep, need surgery.
what's it better?
There's a lot that can go wrong in the abdomen. So we'll talk about same things. Anatomy, pathophys, what we do for them, pre-hospital, hospital, and specific injuries. You know, a lot of these, especially with any significant trauma, most are going to go to the OR, or they're going to have to be managed by surgery. But here's like the take home. The bottom line up front is straight to the OR. For anybody peritonitis, anybody with any evisceration, unstable with a positive FAST, anything, you know, anything we suspect some sort of internal bleeding or intra-abdominal bleeding, and unstable patients with suspected, you know, abdominal injury are going to go to the OR. Other ones we're going to admit for observation if we have like a negative CT, and if we think that there may be some sort of other injury, like some of our hollow viscous injuries are difficult to detect, retroperitoneal structures. So a lot of those ones we admit for serial examinations until we can rule out any of that, like hollow viscous injury or retroperitoneal injuries. And then never send an unstable patient to the CT scanner. We say it, but we do it all the time. All right. Oh, let's see if it's working. Here's our warm-up case. So 22-year-old stabbed in the abdomen, arrives at the ED with abdominal tenderness with diffuse scarring, appears pale, cool extremities. Current vital signs are blood pressure 85 over 50, heart rate 128, breast was 28, SpO2 294, GCS 15. Priority for treating this patient, I mean, obviously our primary survey, ABCDE, they need to go to the operating room for sure. And we'll talk about, you know, how we manage these patients. But, you know, abdominal trauma, very common. You know, quite a significant proportion of our traumatic deaths. We do have, you know, common organs that are frequently injured. So like our liver is probably the most commonly injured, or it is the most commonly injured. But we also, you know, worry about splenic injuries as well, especially during sports. And then patients typically die from some sort of massive intra-abdominal hemorrhage, and we weren't able to get them to the operating room first. All right, so blunt trauma. You know, we have those like compressive shearing force, especially with seat belts, and especially if they're only wearing lap belts, that, you know, usually can be a bigger concern, but we have that, you know, acceleration, deceleration injuries. So on the, you know, the mechanisms kind of helps guide us in what we find on physical exams. So any seatbelt signs are usually pretty significant. And then we can have other concomitant injuries, so patients that fall, they can, you know, land on things, any sort of, you know, handlebar injuries are another concern with blunt trauma, sporting injuries, But anybody with blunt trauma and peritonitis, and any sort of like hemodynamic instability, they go right to the OR for an exploratory laparotomy. And it can happen pretty quickly. Like sometimes we're barely, not even getting through all of our primary survey, and we're like, we got to go straight to the operating room with these patients. And you would think, being this day and age, that I don't think I've ever seen an operating room on the same floor as the ED. So they're all, we always got to go to some elevator, but usually the elevator's pretty quick. All right, penetrating trauma. So it hopefully makes sense. You got some sort of projectile or penetrating object pierces that area, and we worry about whatever damage it causes those internal structures. When we have like gunshots, we worry about that. The fragments can cause, significant injuries if it, depending on what type of bullet it was. You got the energy from that impact to damage a lot of other structures, the transmitted energy. These usually cause significant morbidity for those penetrating injuries. And then everything we're evaluating, what's the trajectory with Selene? A lot of times these patients are gonna, depending on where it hit them, they're likely gonna be unstable. So we may not be able to fully assess till we get to the operating room and they stop that bleeding and resuscitate them first. But most objects we consider penetration of the abdominal cavity if there's any suspect, but anything in the lower chest, we consider it's usually usually we say below the nipples is when we're going to consider that possibly being an abdominal injury as well. And then, we want to concern ourselves anything in the flank, back, pelvis. We worry about an abdominal injury or that it has penetrated the abdominal cavity. And then eviscerations need to go straight to the operating room. Everybody knows what evisceration is, right? Non-insult anybody's intelligence. All right. So basically some sort of organs are sticking out of the abdominal cavity. So sometimes signs can be obvious, like especially for patients in extremis, they got peritonitis, or we have an evisceration. But a lot of times there can be occult injuries, and that could make it a little bit more difficult for us when we're evaluating them in the trauma room. But they can have significant head injuries associated with it, and we may overlook that abdominal injury. We may not notice it. There can be referred pain, so like your spleen may cause like a left shoulder pain, your liver, right shoulder pain, things like that. If they are intoxicated, that can make our exam a little bit more difficult. Language barriers. We always want to know if the patient's on anticoagulation. They can have a higher risk of bleeding, so that's always concerning. And then we always think in our young, healthy patients, they can compensate extremely well until they fall off that cliff. But things we're looking for is that like seatbelt signs. So do I have ecchymosis coming across the abdomen here? That's going to be more concerning for some sort of intra-abdominal injury or maybe a surgical pathology. And then you think about other direct blows, so, altercations, we always have like that classic board question of like a handlebar injury straight to the epigastrium. And then other things that can mimic it, we have like rectus hematomas, so they can look like an intra-abdominal injury, but really it's a hematoma of those muscles, so that's something we have to consider as well. And here's a great CT scan of a rectus sheath hematoma. So it's not penetrating the intra-abdominal cavity, but you have a significant hematoma there. There's like some signs on a physical exam, like Carnet's sign when they tense the abdomen. The pain is supposed to increase. It's kind of difficult, so we don't really, I've never looked for that sign. Maybe I'll start telling my patients like, yeah, squeeze your belly. Let me see. Show me your abs. I want you to tense. Usually we're gonna have to. These patients will be stable since it's not penetrating the intra-abdominal cavity, and we'll catch it on CT scan. But we, initially we assume that it's gonna be in the intra-abdominal cavity until proven otherwise. And you guys remember these signs from your last test? Colons and Gray Turner. Yep. So this is, indicative of some sort of retroperitoneal bleeding or hemorrhage. And then solid organ injuries can be, if there's no penetrating injury, it can be difficult sometimes to diagnose. So a lot of times, this is when we're gonna be performing our FAST exam. And if we have a positive, we are gonna take most of these patients to the operating room. If they're stable enough, we might get a CT. But sometimes the only thing we maybe, initially you might see like an increase in that pulse pressure. But sometimes the bleeding can be minimal and it might get overlooked, especially if they have other injuries, like in, motor vehicle accidents, you'll a lot of times see, some like lower extremity long bone fractures, which may be complicating our examination, or it may be tricking us in our exam. And then we always worry about delayed ruptures of organs, so that's why we tend to admit most of these patients to the hospital for serial exams if we can't definitively diagnose them with our initial exam and CT. Here's our classifications of shock. Again, and the bottom line is you can lose quite a bit of blood, like, 30% before you start to become hypotensive. So, we want to make sure we're looking at all their vital signs, like, tachycardia is kind of one of the first ones we start to notice, especially on exams. So you need to start thinking maybe they're trying to compensate and bleeding somewhere if we can't visibly see it. And that's what the issue is with the belly, is we can't, visually see bleeding in there. So we have to have a high suspicion for it during our traumas. And like I said earlier, you get referred pain from these, so it can sometimes be tricky on our exam and what's going on. So especially with like polytrauma or motor vehicle accidents, we might be thinking, well, maybe they like fractured, one of the bones in their shoulder or something like that, but really they have some sort of liver injury. And then we always want to think about other considerations that could predispose them to like a splenic rupture. So, our mono patients, pregnancy can increase the risk for splenic injuries, but both of them have a high risk for hemorrhage. So, if they're stable, we'll CT and try to figure out further. Actually, look it up once, I want to say for mono, because I was thinking like, I've probably not died, if they don't have, rapid strep's negative, I'm like, get out of here. They got whatever, you got viral pharyngitis. And I was wondering, because it's usually a lot of adolescents and teenagers we see strep in, and I'm like, I wonder how often like I'm undiagnosing mono and they get some splenic injury. And actually, and I want to say last time I looked up, the most common cause of like that splenic rupture is atraumatic. So like it's not really associated with trauma. Yes, trauma could certainly worsen it, but it was very low percentage of patients that had mono and some sort of trauma caused that splenic rupture or hemorrhage. It was actually spontaneous in most cases. And it made me feel better that I hadn't like misdiagnosed people and they're getting splenic ruptures. All right, so hollow viscous injury, these are ones that always concern us because they won't have like significant symptoms of blood loss with some of these hollow viscous injuries, or it doesn't manifest initially because it's those retroperitoneal structures. So, we worry about, a big one is like our duodenum or the celiac of the duodenum, the pancreas. Those are some of the structures back there that can have a delayed presentation, or it may not present initially with the same peritonitic signs and symptoms that would make us take them to the operating room. So we need to have a high suspicion in our trauma patients based on their mechanism and our physical exam. And here's, a little bit on how that patient may present, what kind of pain they have. So, gastric contents may produce immediate pain, but we might not have like bacterial contamination, so it can delay some of those signs and symptoms. So the big thing is always be suspicious for some sort of hollow viscous injury or those retroperitoneal structures. And then there's, anything in that epigastrium, we'll worry about the pancreatic injuries. Commonly on the board test, it's like some kid riding a bike, or it's like some skier and took a ski pole to the belly or something directly to that epigastrium. So we need to kind of be suspicious for some sort of pancreatic injury. Most of them are going to present the same. They'll have some sort of belly pain in that area. And then we just need to have a higher suspicion there that they may have an injury. And if we don't find anything initially on the CT, these are ones we tend to take to the hospital for serial monitoring. Same with the duodenal injuries, they present similar to the pancreatic, and they may have a very mild or asymptomatic exam, but we need to have a higher suspicion for these, just because it can be delayed with how much time it takes for the hematoma to expand. And they may not be peritonitic from those gastric contents initially, but most of them are from like the deceleration injury, especially people wearing just lap belts. We want to consider a hollow viscous injury. So if they didn't have a shoulder belt on, that's gonna raise our suspicion for any of these duodenal injuries. So diaphragm injuries, these are not common, but they can cause severe mortality. So any rupture in that diaphragm can cause those abdominal contents to kind of perforate into the lungs. And typically the patients will complain of symptoms. Sometimes we can see it on our chest x-rays as well. So if we have any suspicion for this on a chest x-ray, it may kind of look similar to might look like a hemothorax or some sort of abnormality in there. So we'll put an NG tube in there to get an image of that on it if we have any suspicion for it. Because then we'll see that NG tube kind of wrapped into the lung. But these patients are going to be surgical patients. And they get, it can be caused from any blunt trauma, penetrating trauma. We just need to have a suspicion for it. It's usually on the left side. And these are ones that need to go usually straight to the operating room because of that high mortality rate. All right, how are we diagnosing all these? So we have, all kinds of different tools we can use. None of them are 100%. So our, best tool is going to be a combination. What's the MOI? What do we see on our physical exam? And then usually we're doing a fast exam during our primary survey, which can be helpful if we see any free fluid. And then any hemodynamic instability without other causes, we're going to assume that there's some sort of intraperitoneal bleeding and they need to go straight to the operating room. So when would we not do all of those? Patient's hemodynamically stable, they have a lower mechanism of injury or, low speed motor vehicle crash, no seatbelt sign, benign exam, and our imaging is all negative. We may or may not decide to do imaging at that point. So if it's a very minor accident, they're in the emergency department, there may be times where all we do is a physical exam and we're able to discharge them based on that. But most of them, especially if they're presenting to a trauma center, they're going to get an entire workup and we're going to rule everything out. So that's our EFAST. We get our chest x-ray, CT scan, and then all of our trauma labs that we talked about during that first lecture. But our FAST is going to be probably our best tool for this, and it's going to be the most rapidly performed. So because we can do it in the trauma room, we don't have to take them to a CT scanner, and usually we have enough people where somebody can do the FAST exam while we're performing the rest of our primary survey. But it's quick, it's I think it's on another slide, but it's like usually less than 4 minutes, usually a lot faster than that once you're proficient. I would say it's definitely under a minute most of the time when we're performing these FAST exams, but it can help us identify that free fluid. We don't know where it's coming from in those patients, but we know that something is bleeding intra-abdominally or in the peritoneum, and they need to go to the operating room. And then here's our bandages. It's like the name says, fast, it's rapid, non-invasive. We don't have to inject any fluids in there. We're not exposing them to a bunch of radiation. We can use it in pregnant patients or other patients we may have concerns with doing a CT scan or exposing them to radiation, which is why we like it. And like I said, 4 minutes or less. I think once you're proficient, we'll do it usually a minute or less. And I think, most places, and for the trainees, a lot of times we'll have you guys doing the FAST exams or any students, so you'll be the FAST person, which will at least get your foot in the door there, especially like in a place like BAMC that trains a lot of people. It's hard to get procedures and on everything, so be proficient at the FAST exam so you can get your foot in the door there and on the patient, and then you may get other procedures. So I would, make sure you guys are practicing it while we do our block 5 and becoming proficient at it. You're not gonna see any abnormals, but just once you, as long as you know what normal looks like, you'll know what an abnormal is when you see it. So we get, the most, the blood tends to first show up at Morrison's pouch or like those most dependent areas. So that's why, our single view of Morrison's pouch typically what we start with for our FAST exam. And then we can identify it real quick, extremely quickly that, okay, there's some sort of abdominal bleeding, they're gonna need to likely go to the OR. But, like, even CT scan can't detect that those retroperitoneal injuries initially, neither can the FAST exam, so there are limitations to all these. And then we have other applications, so we can look for any bleeding like suprapubic, we're gonna look at the lungs for any sort of pneumothorax, lung sliding, so it has, a very diverse array of what we can look for. We can also check intravascular status, so we look at the inferior vena cava, and we can look at their volume status, which can be helpful as well. And it'll make more sense once we're practicing these on each other during our next block. Anybody with positive FAST and instability, they're going straight to the operating room. If they're stable enough, we have a positive FAST, they may or may not go to the CT scan. And like it says, they used to do like the peritoneal lavage, DPL, which we don't do anymore because ultrasounds essentially replaced it. So we don't have to do any crazy diagnostic peritoneal lavage, which if you guys know what that is, they cut, they make an incision in the abdomen and they place like a catheter in there with some fluids, and then they lower the bag below the bed, and if blood comes out, it was kind of a wild thing, but that's how they did it before we had the invention of ultrasound. All right, what do we see on this? This is going to be our right upper quadrant, so Morrison's pouch. Does it look normal? Yeah, looks normal, right? That would be a negative FAST. Let's see, this is, it's hard to see. Let's look at it again. Did you guys see fluid in there? Sometimes the screens aren't very great, man. Let me, where's that other light at? You guys see that? You got like a fluid stripe running. Let me see if I can get my little pointy thingy on here. So you got like a fluid stripe running here, and that's typically in the right upper quadrant where the fluid hides. So typically in between that kidney and liver, and then we'll cover it more extensively in block 5, because on the left side it's actually below the diaphragm. So it's a little bit different, depending on what side we're doing that fast on. But the gold standard, if they're stable, is going to be our CT scan with IV contrast. So we'll do abdominal pelvic CT with contrast, and it, very, it's great at identifying any of those like liver lacerations, like splenic lacerations, or any other intra-abdominal injury. Once again, it can evaluate the peritoneal structure, but sometimes we may get delayed presentations like the duodenal pancreas, hemorrhage or rupture. So those are ones that it may not detect initially, but this is what we're going to use for our gold standard testing. Yep, it's got a high ion, you get a lot of radiation with it. Nowadays though, it's relatively minimal. We got lower radiation in them, so it's not as significant as it used to be. The issue is they have to leave the trauma bay to go to the scanner, and then the scan takes time. So that's typically where we have issues. So try not to send any unstable patients to the CT scanner. That's where they go to die. We also, we don't want to expose kids to radiation, so we have, we need to use our clinical judgment at this point on whether we think we need a CT scan. So sometimes, if we suspect an injury, if we have a concern, we're going to scan them. But if we're on the fence, a lot of times we admit them, the younger patients, for serial exams, so we don't expose them to as much radiation. And And then we try not to repeat CT scans or do serial CT scans for our patients, so especially when we transfer them. We try not to repeat them, although sometimes we do. All right, what do we see here, other than positive arrow? Yeah, we got a splenic laceration there, so, you know, you guys are, it's probably been a while since you did radiology or how well you covered it. We do a lot of CT scan in the ER, so on your, at phase 2 on your rotations, we'll have a big, we call it a PACS machine, but it'll be a big viewer with all of our CT scans or any image on there. So make sure you guys are looking at them when you're there, asking your preceptors, what are you looking at? Or what are you looking for? So that you guys can become a little bit more proficient in evaluating CT scans, but it does take some time. All right, so penetrating trauma, same, you know, we treat all of our trauma patients the same, but anything penetrating, we have a higher, we're gonna have a higher suspicion for intra-abdominal penetration of that peritoneal cavity, so they're likely gonna go to the operating room. There are very rare instances where we can locally explore it if we don't think it violated the peritoneum. That's gotta be in a stable patient that doesn't have any other like concomitant injuries with it. But very rarely do we do that. Typically they'll take them to the operating room and do an exploratory laparotomy to verify, but surgery will cover a lot more in depth on the indications for that. As you know, I'm not doing that in the ER, usually the surgeon's doing it down in the ER and establishing whether it violates, penetrates the peritoneum. And then what's the treatment? Like I said at the beginning, exploratory laparotomy is gonna be our treatment for any significant intra-abdominal injuries. So anything we think violated the peritoneum or penetrated it, they're gonna get that. Anybody with intra-abdominal bleeding, they're gonna get exploratory laparotomy. And that's gonna be the definitive way to say that we have any sort of significant injury in the peritoneum or cavity. But, you know, the big indication, anybody that's hypotensive, you know, we suspect we have a penetrating injury to that area, or any peritonitis with, you know, hemodynamic instability, those are going for surgical exploration. Nowadays with, you know, our CT scanners are great at being able to diagnose and stage or grade the different sort of solid organ injuries, which, you know, that's what we see a lot with blunt trauma. So like liver lacerations and splenic lacerations aren't all immediately going to go to the operating room if they're stable. So our CT scanner can help grade those and decide, you know, stage 1, 2, 3, 4, I think it goes more for liver. And our goal is not to open those patients up if we don't have to. So a lot of times we'll admit them for serial examinations and to determine whether there's any continued bleeding. If not, the body usually heals itself pretty well. So a lot of those injuries we try to manage non-op now for those like lung trauma, solid organ injuries. All right, there's Reboa, which we talked about earlier in another class, and that's something we can use in lieu of like our, not in lieu of it, but something that we can use as a temporizing measure instead of a resuscitative thoracotomy. So there's a good picture here. I don't know if it's in the latest T3 guidelines, 2026, but I think it's still in there. There's always studies saying it's good, it's bad, it's good, it's bad. So it's, you know, not something you're gonna do unless you have a surgeon or you're at some forward deployed and you're a lot more highly trained. But here's what it is. You know, they place basically a large catheter through the femoral artery, and we feed it up, and there's different zones we can place it in, and we basically occlude any blood flow distal that area so that we can keep all of the blood in our vital organs like the brain, the heart. But they're still gonna need surgery. I've kind of already said it. Hepatic splenic injuries, you know, non-op management is going to be our treatment of choice. So if they're hemodynamically stable, we're going to grade those injuries or stage them based on our CT scan and admit them to the hospital. you know, if they're on some sort of anticoagulant, you know, reversing those agents, you know, it doesn't show a ton of benefit. It just kind of depends on where the injury is and what's going on, but it's not something you guys need to get your heads wrapped around or worry about. But just always remember, if the patient's on anticoagulant, they have a higher risk of bleeding, and we need to think about that during our evaluation. And then what's going to be our disposition? So anybody hemodynamic instability, and we suspect, you know, an intra-abdominal injury, they're going to go to the operating room. We rarely discharge patients unless it was a very low energy mechanism. It's an injury, but most patients are going to be admitted for serial examinations if we suspect an intra-abdominal injury, but we have normal vital signs and their imaging is inconclusive or it's negative, we admit those patients. All right. I know it was a quick lecture. You'll cover it a lot more thoroughly during your trauma lectures for surgery and what sort of procedures they're actually going to do for these. This was an accident in Dallas, but there was probably 2 drops of rain on the roadway that caused this. Rain in Texas, never good. What questions y'all got?